Okay, good morning. I'd like to welcome everyone to our grand rounds and a few housekeeping items. Please remember to complete your surveys. These remain critically important. I'd like to remind everyone we're video conferencing and videotaping, so please use the microphones to ask questions. And YouTube channel next week will be displaying the video of this conference. And last, tomorrow we have our exciting Heart Failure Summit, February 9th, so please feel free to come by. I know registration is filled, but we have options for those that come on site. So please join us. It's a real privilege for me to introduce my colleagues, Dr. DIPAN J and MIN Chang. Dr. DIPAN J began his academic career at Duke. This was back in 2002, where he was part of the MRI efforts there. Was part of a Heart and Vascular Institute in Nashville before joining our program in 2008, and really has revolutionized how we image patients with a new option of cardiac MRI. And really his expertise has helped us from heart failure to vascular to, as we'll learn today, prosthetic valve evaluation. So it's just been a tremendous, robust program. He's extraordinarily well published in this field and is really recognized as a national leader. MIN Chang began his academic career at University of Wisconsin. This was back in 2003. Then he was the head of the nuclear lab at the VA Center and joined the Heart and Vascular Center here back in 2007. And expertise ranging from echo to nuclear cardiology and a real focus on cardiac CT. He's published several good both reviews and original work looking at cardiac CT and its association with outcomes. So together they're positioned nicely to lead this discussion on advanced cardiac imaging and the management of patients with suspected prosthetic valve dysfunction. And certainly not needing an introduction is our distinguished panel. And DIPAN and MIN, you guys can take it from here.
Okay, so we're going to start. So the objective for today is, in the end, hopefully to try to propose an algorithm for how you should utilize advanced imaging when you're evaluating patients with prosthetic valves. Because I think it's easy to say, get every test. But really what we're going to try to show you is what the strengths and weaknesses are of each modality and then ultimately give you a suggested approach. And so we thought we'd do this as a case-based approach. So we're going to have Dr. ALPANA SENAPATI, who's one of our senior cardiology fellows, who's also going to be an advanced imaging fellow next year. She's going to start us off with a clinical case, and then we'll follow that up with some discussion, as well as another clinical case and some more discussion. And obviously, we've got an esteemed panel here who can chime in as far as their wisdom over the years. So, to start off with, ALPANA, please.
Yes. Thank you, Dr. Shah. So I'm going to initially start off with the case that we had a little while back. It was a 61-year-old female. She has a history of bicuspid aortic valve and underwent mechanical St. Jude's 23-millimeter aortic valve replacement in 2000. So she presented about 10 years later to a heart failure service in 2011 with evaluation of worsening heart failure symptoms, class 3 symptoms, really progressive over the last 2 to 3 months and more so over the last 6 months. So she has a history of sick-sinus syndrome, underwent pacemaker implantation in 2005. She has a history of prior myocardial infarction in 2010 and 2011. That was in an outside facility, and a history of 2 episodes of sudden cardiac arrest and ventricular tachycardia. At that time, she underwent coronary angiogram, which showed that she had non-obstructive coronary artery disease, and her LV function at that point was less than 35%, and she underwent a BIV device in 2011. She does have a history of recurrent atrial fibrillation flutter and eventually underwent atrial fibrillation ablation and several times in the past in cardioversions with really no significant improvement in her dyspnea. She does have a a diagnosis of non-ischemic cardiomyopathy, sudden cardiac arrest, and hyperlipidemia. So she does have a significant family history of bicuspid aortic valve in a first-degree relative and sudden cardiac arrest in an uncle at the age of 45. Listed are her medications: carvedilol, Coumadin, simvastatin, mexiletine, digoxin, amiodarone, and furosemide. So an exam, she's about 5'6", 230 pounds, BMI of 37. Blood pressure was 117/74. and a heart rate of 77. Pulse was regular, JVD was up, no significant rails on exam, and she did have a mechanical S2 sound on exam and some lower extremity 1 plus edema. Pertinent labs for her, she had normal renal function. Her INR was subtherapeutic most of the time, going over past records, about 1.5 to 2, and she was not anemic. Her hemoglobin was 13.8. This is her EKG. She's ventricular paced. And this is a series of her echocardiograms here, which I'll play. As you can see, she's about 230 pounds. She was a technically difficult study to do. So really looking and evaluating the mechanical prosthetic valve was a little bit difficult in this patient. However, on vitals during the echo, her blood pressure was about 104/68, heart rate at 64. Doppler interrogation of the valve showed that she had a symmetrical rounded jet, was a little bit concerning. So that was a clue on the echocardiogram, despite not having optimal images on the peristernal and the apical chambers. And she had a peak velocity across the aortic prosthesis about 3.6. and a mean gradient about 33, which is a little bit concerning that this patient may have a severe prosthetic aortic valve stenosis and or obstruction of her valve because of the high gradient and also the rounded contour, and the jet peaks a little bit later, which is a little bit concerning as well. So to the panelists, what would you recommend in this case? Is this information enough, or would you pursue further testing?
Well, she had also another finding, which is the ratio of her integral of the LV outflow to the integral of the aortic jet was very low, which is another indicator. So from the point of view of certainty that this valve is obstructed, I would say the certainty for that is 99.99%. So another question is why? Is it a panus? Is it a clot? Usually, until recently, the guidelines have said, well, the next step is a TE, relatively easy, simple to do, no radiation, no other issues. So normally we would proceed with the TE. Obviously now we're going to have other ways, but I think if you follow a traditional mode, it would be reasonable to proceed with the TE.
Yes, and that was exactly what was done in this patient. So further imaging with a transesophageal echocardiogram was performed. These are some of her images here. And as you can see, really getting a good interrogation of the mechanical aortic valve, especially on a transesophageal echo, can be a little bit difficult at times, but you do have some evidence that maybe the mechanical prosthesis is not really opening or functioning that well, and you do have some indication that there is some paravalvular regurgitation as well. So moving on, during her time at the transesophageal echo, her blood pressure was 100/55, heart rate at 64, and during this time her INR was 2.1. So based on the transesophageal echocardiogram, the mechanical prosthetic aortic valve wasn't really well visualized in this case, and there may be a little concern that maybe one of the leaflets is not quite opening or is less mobile. And so in this case, to the panelists, what would you recommend as the next step in further evaluation of the valve?
My question would be, how confident are we that this is paravalvular? I mean, I see the little jet on the short axis views. I didn't see that it was outside the surgical ring. It's asymmetric, but if you have one of the two leaflets that isn't closing properly or opening properly, that can give you an eccentric jet. So far, I'm not sure, and we've dealt with this clinically quite often when you're considering plugging and fixing things. It's not trivial to figure out sometimes whether it's actually paravalvular or not. So finding a hole outside would be useful. So if there were an imaging modality that could do that, that might be helpful.
Sure.
The other thing is they mentioned that it appeared to be a small prosthesis. At 23 millimeter, St. Jude really should have excellent hemodynamics. So if you find a valve that has any real abnormality that's a 23 millimeter, then that's almost certainly dysfunctional. We use fluoro quite a bit, actually. If you can get a diligent fluoro, the pyrrolite carbon leaflets are actually radio opaque in their long axis. They're not they're very thin, so if you're looking down on the leaflet, you see right through them, but on the edge, you can see them very well. If you can spend a little time, get the right views, you'll see asymmetric movement of these two little lines. And that's what we look for as the definitive proof of any abnormality or asymmetry of that motion means the valve is not functioning correctly. And at this late stage, 8 years post-op, then it's almost certainly going to have an element of pannus involved in it, plus or minus clot.
I mean, I agree with Gerald. When you looked at the hemodynamics, I was very concerned that because of a 23 valve, if you look at the normality, I mean, this is an obstructed valve. There's no question about it. It's obstructed and regurgitant because most likely there is something impinging both opening as well as closing. So if I want to bet, it is actually valvular regurgitation as opposed to paravalvular. You already have a TEE that tells you most likely. It's not, that's the issue with TEE and prosthetic valves in the aortic position. Quite often you're not going to see the valves well hinging and opening and closing, so you need another modality before going further. And I think the big question is a reoperation in a mechanical valve or a lytic agent if the patient is has significant risk, and so you have to kind of make that decision. I would agree with Gerald that if a decision, irrespective of what the finding is to go to surgery, you really don't have to do a CT angio. You could go for fluoroscopy, and it confirms for you that indeed it is a dysfunctional valve, and then you proceed with surgery. But if an issue is this thrombosis, is this pannus, or most likely a combination, a CT angio would be very good because it tells you about motion as well as is there a thrombus on it to help you ultimately make that decision.
So I guess I should talk a little bit about CT. That was kind of, thank you, Bill, for the intro. So CT is actually very robust, particularly looking at mechanical aortic valves or mitral valves in terms of looking at leaflet motion. And because they are radiodense, and we can see them very nicely with contrast. So we've had many cases where we've looked at these particular types of valves and can see whether they're not moving properly. The other issue that was brought up in terms of the etiology, and one of the ways in which we look at CT is to look at whether there's fresh thrombus there or whether there's pannus there, and we use Hounsfield units to kind of look at these valves. And so if you find an area around the valve where you think there's pannus or vegetate or thrombus, and you look at it, it has less than 90 Hounsfield units, which would be consistent with blood, that's usually fresh clot. And those actually respond very nicely to anticoagulant therapy and would be like the first order of business to try that first. If you have somewhere between 90 and 145 Hounsfield units, that's more consistent with an older thrombus or an organized thrombus, which may or may not be really responsive to anticoagulation therapy. And anything over 145 is considered to be pannus. And so, and the other thing, not only can you use the Hounsfield units to better describe what this might be, but also in terms of looking at how obstructive the area is and the extent of it. The other thing that was interesting about this case is that there was some question of a paravalvular leak as well, or whether there was central leaking. And like I said, we can see very nicely with these mechanical valves whether there is any central aortic regurgitation on a valve like this, as well as whether there's a stenotic area because it's not opening properly. And we can also look, particularly if there's any anatomic formation around the valve that would lead to a paravalvular leak. So we can see contrast going around the annulus into the ventricle. We see this very commonly in patients who have endocarditis, where we find fistula formation. And although we're not a functional technique in terms of looking at flow, we can certainly see anatomically those kind of paravalvular abnormalities where you see fistulas around the annulus going from one chamber to the next. So I think in many respects, CT gives you a very good look at the entire structure and can certainly look at the valve nicely. The other thing I want to mention is that if the patient were to go for surgery, and if the patient did have coronary disease, which this patient doesn't have, or such as bypass grafts in the past, a class 1 indication for CT is to do preoperative planning with CT to look for the location of bypass grafts so that when you go into the chest, you don't have a potential for, destroying a graft in the interim. And the last thing I want to say is that CT is not first line for looking at valves, okay? So, but if you look at the guidelines and if you look at appropriate use criteria, it is an appropriate study in patients who have equivocal other studies, okay? So I think that's also important to keep in mind.
Yeah. Also, don't be surprised if at times you see a dysfunctional valve that is not opening and closing well, but you don't see anything underlying, meaning at times the pannus is so strategic in affecting the hinges of the valve that you may not see anything. You see a valve that is stuck or poorly mobile, and we've shown that in our previous investigation. So if you don't see anything, most likely it's pannus, right? And if you see a thrombus, usually it's large. I mean, these valves are rather small, but the hinges are so tiny that a small impingement on that hinge may actually affect it.
And then the other thing about the St. Jude valve is that the annulus has thickness, but then it has a downward piece that comes down to hold the hinges of the leaflet. So the leaflet hinges are below the plane of the main annulus. So when you put the valve in, they are in close proximity to the wall of the ventricle. And if you're putting a biggest valve in you often have trouble seeing those hinges even when they're normal. So that can, and it's right up against the wall of the ventricle, very susceptible, as Bill said, that just a little bit of pannus can cause a major problem.
Thank you. So this patient did undergo a cardiac CTA, and as you can see here, there's some periprosthetic hypodense material surrounding the valve, highlighted in the yellow areas that was concerning for a pannus, and the Hounslow units was consistent with a pannus formation, as Dr. MAHMARIAN had pointed out. Now this is a further interrogation of the valve. We can get systole and diastole, and we can really get a better understanding of what is going on with this valve. And as you can see here in this SENA loop, that one of the leaflets is completely restricted. It's not opening at all, and really the other leaflet's not opening quite fully as well. So really I think this is a great example of how CT can be useful in really assessing the etiology of these high transvalvular gradients and really looking at the valve. So the clinical course of this patient underwent surgical redo mechanical AVR, and on follow-up visit, really just a month ago, she was having class 1 to 2 symptoms, so she's doing pretty well. And really explantation of the valve, you can see that there's all this fibrous material in the periprosthetic area, which is consistent with pannus, and really repeat echo show that she's doing quite well and she had normal prosthetic function. So I'll end with that. Thank you.
The other issue with this patient is a choice of prosthesis for the second operation. Many of these people have done well for 8 or 10 years with their mechanical valve, which was put in appropriately because they're in their 50s. And then we see them for a reoperation in their 60s, and some of them have a history. Her INR noted was 1.5 to 2. And if they've had problems with their coumadin over the years, something to consider is using a bioprosthetic valve when they come back in their 60s.
Okay, thank you, ALPANA.
One other thought, since we're talking about mechanical prosthesis, is also I've noticed that we've lost the art of fluoroscopy in the catheterization laboratory. And these are very thin valves, so you need to know how do you evaluate its motion. You gotta be perpendicular to the side of these prostheses, otherwise you're not gonna see them well and you're not gonna see the angulation. So the view of which that you're gonna take it at is where you see this valve either opening or closing. So you have to see the maximal density. If you visualize it in a different portion, you're not gonna be able to see these angulations. So, a A fluoroscopy would have definitely given you the diagnosis here.
And then one quick thing, you notice one leaflet's moving some and the other leaflet's not moving at all. This is a common pattern. The valve starts to clot off. The more clotted off leaflet will jam and stop moving, then the whole force is on the other leaflet, and that generally manages to keep it moving, at least till the patient can get in and get taken care of. So that's a very common pattern, one completely jammed leaflet and one partially moving leaflet.
So Dr. Barker has been very quiet here. I guess you cannot go in and clip that valve.
No, no.
However, I have a question for you. No, this is.
Can you put a
Do,
TAVR?
do you see? Do you see in the future? Is there any option in the future for development of systems that maybe will suck things out from those valves?
No, I mean, the only thing I was thinking about watching this, is there a way to prevent this? You know, what is the pathology of the pannus? You know, is there something like giving someone a sirolimus, something to, like we deal with in stents to prevent pannus formation, might be beneficial. You know, I don't know anything once it's formed, you know, how to deal with it. I think that would be a challenge. And then just for the fluoroscopy, it is a little bit of a lost art. Kleiman and I frequently get called in to help out to figure out how to visualize these valves. And just for the guys who do cath, it's usually an areocaudal or aleocranial, and you want to mag up and get a long axis and a short axis so you can see both of these leaflets.
But the question is on the algorithm, when fluoro versus CT. So what's the advantage of fluoro over CT?
Well, fluoro is cheap and quick. I mean, you can do a fluoro on somebody in 5 minutes.
Well, I guess from the issue of CT is also quick. It's an 8-second test.
We get a lot of these people sent in, I've had a plain old cardiac cath. A lot of these people are referred in.
And of course,
a lot of these people are referred in from the outside. They've had a cardiac cath, and it's not uncommon on the fluoro footage you have there, incidentally, in that study to see it enough to make the diagnosis.
yeah, and so one other thing I
The
just want to
concern
mention
is the A portion of the CTA.
the which the acquisition.
No, it's the angiography portion,
Oh, yeah.
meaning, you know, these patients are sick enough, and I mean, this individual had a good GFR, good
Right,
renal
right, right.
function, everything
Well,
else.
may I make a correction?
Yeah, so of course, anytime you give contrast, that's an
Exactly,
issue.
I mean-
But actually, you know, the other thing that I just want to mention, if you just want to see the valve leaflets and nothing else, you can do a non-contrast gated study, and you can easily see whether that's a dysfunctional valve or not. So you don't necessarily have to give contrast. If you want to look at the mechanism, the potential mechanism of why, then you need contrast. But just to look at the valve itself, just a mechanical valve, you don't need any contrast. You can just gate it like you would normal gated study to the EKG, and you'll be able to see the leaflets open and close, just like you would on fluoro. And the other thing about CT is, my voice is going up, is that we're friends. I know, it's passionate. Is that it is three-dimensional. I mean, you know, you get a complete three-dimensional view of the valve, you know, so you get a complete view.
Mike, we need a mic. Who's the portable mic carrier? Who is it? Please.
She's got one.
Coming your way.
Thanks, that's great. But as you know, in the aortic position, that's true with both leaflets moving. In the mitral position, with the mechanical prosthesis, certainly if it's oriented in the so-called anatomic position, you can get a lazy leaflet. And you can have one leaflet not moving simultaneously with the other leaflet, but that's not necessarily a sign of thrombus or pannus. It just has to do with the flow. So that doesn't mean that there's a mechanical problem with that prosthesis.
But, you know, again, I would just like to mention that with CT, we've looked at many mechanical valves. And usually, a lot of times it's in patients who are actually going for coronary disease evaluation and have mechanical valves where we just happen to gate them and look at the valve's function. And just as in the aortic position, you can very nicely characterize the mitral valve as well as the aortic valve with CT. So
Tom has a very good point, meaning,
well,
at
both
least for the
cases.
imagers, is that not infrequently, depending on the ventricular size and function, there's a vortex in the ventricle. So the phenomena that you're describing, Tom, is more often in diastole, as opposed, in late diastole, where you have a vortex that comes in the ventricle, and then that vortex that comes in would close, almost close, the leaflet, the medial leaflet of that valve because of vortex. So it is not a dysfunctional valve. When it opens up completely normal. But because of the vortex, depending on the situation, you will see that. You'll see that also when, like in this patient, when you have a conduction abnormality. If you have a bundled branch block, you will see, because of heterogeneity of the ventricle, you will see that.
In a normal valve, the vortex is clockwise, looking from the apex, and in these prosthetic valves, it's counterclockwise. So you get this thing projecting right up under the valve. The leaflet should open fully, but the leaflet motion may be slightly delayed. You'll see, instead of doing that, you'll see one leaflet just slightly lagging.
Dr. Chang.
Great. That's why we do a grand round like this, to generate a lot of lively discussion. I just want to go through quickly some cases with CT to highlight some nice examples that we have in our lab over the last several years. Just quickly, why we do CT or MRI compared to transthoracic and TEE for prosthetic valve assessment is because CT has less artifact with aortic valve, as we saw, and provide better anatomical information with regard to perivalvular and aneurysmal structure, like Dr. MAHMARIAN mentioned. And most importantly, I think the great future for CT in this regard is a 3D visualization, and it will be very helpful for pre-surgical planning or even percutaneous procedure or intra-procedural guidance as well. MRI, the major strength that DIPAN is going to talk about is obviously the quantification of severity specifically in those regurgitating lesions, and also very helpful in localization and origin of the jet. For obstructive lesion, CT can measure anatomical orifice area, can look at motion, opening angle, and get some idea etiology of the obstruction. It's a quick case of a patient with degenerated bioprosthetic tricuspid valve. As we can see there, it's both generate stenosis and regurgitating lesion. The leaflet doesn't close up, and you can planimetry, like in this case, very nicely, 1 centimeter square. This is another case that we were just talking about use of fluoroscopy. This is a very interesting case of a young patient 4 days after redo AVR, have apparently a defective prosthetic aortic valve. I just want to mention that about the lost art of fluoroscopy. I think one of the last case what we did was from one of the most senior interventional cardiology in our hospital, and he told me it's a lot easier if I get a CT than me spending in the lab trying to figure out the angle. So I thought, just interesting. It's another case of, I think this is Dr. LAWRIE's patient, very accelerated, failed bioprosthesis. Interesting case, 6 months after valve surgery, has tremendous amount of pannus in the biological valve, and as here seen by the pathology, and also explanted prosthesis. And this is becoming obviously our favorite test for our valve team, 4D CT. That's what they want, 4D CTA. There we go. A patient with biological valve with clot in 2 of the coronary sinus. Very nicely seen in this 4D and 3D rendering of the aortic valve. Endocarditis, the main strength is not to diagnose endocarditis with CT, but rather than assessing the complication caused by the infection. As this case here showed the T in the left side, clearly there's a fistula abscess around the prosthetic valve, but it's not until you do the CT you can see the true extent of this very complicated infections. This is obviously essential, I think, for the surgeon to know before they go in, if they think that surgery is an option. And this is one of the cases that we've seen a couple of years back, the patient with the St. Jude's prosthetic valve coming with heart failure and fever. You can see very nicely, very high grading across the prosthetic valve, and this patient also had a history of aortic dissection repair. Transthoracic is very suspected vegetation, and TE confirmed that, and CT was done to look at the coronaries. As you can see, in large mass vegetation, CT can also reveal the location and movement of the mass, but for small vegetation, CT oftentimes can miss the vegetation. So by no means you should do CT to diagnose vegetation if there's a suspicion. What's interesting is, in addition to reveal the location and the mass size, in this case, I don't know if you could appreciate, in CT you can see a little extravasation during systole of the contrast, very small puff from the LVOT to the RV fistula. As you can see that in the arrow during systole, you can see a little bit of contrast, and diastole does not. And this was also confirmed on the surgery.
So then on the previous case,
yes.
Since this is a nice discussion, go back a little bit one more. You have quite a bit of artifact here from the prosthesis itself. Can you modulate that depending on the acquisition parameters? Because then we get into trouble again of being able to identify motion as well as mechanism.
It's absolutely right on, and the major challenge of the CT. And we are currently we're going to put in a grant to look at this problem, looking for different imaging parameter, software, post-processing, acquisition parameter to see which one will be the best in eliminating these artifacts. So stay tuned.
Yeah, so Bill, there are ways to get around that. And the other thing is, one of the things we use is that usually we look at a maximum intensity projection, which accentuates the high Hounsfield unit areas. But we can go to average or mini MIP, what we call, which actually then attenuate or enhance the lower attenuation parameters. And that really kind of helps sometimes be able to see things more clearly. The other thing is that usually when you have beam hardening, which is due to those struts, you can easily identify that because you get very high negative Hounsfield unit values, which are not physiologic. So you get minus 50, minus 80, minus 150. I mean, it's not physiologic. So when you see that it's an artifact. Yeah.
And one last thing about management of patients with suspected endocarditis and complication prosthetic valve is PET CT. Obviously, this is an area that we're very interested in getting to. That's already make it to a European guideline for management and effective endocarditis in patients with possible infections after TE, still with some suspicion. PET CT is a very good option.
I just want to make one other statement about that. I mean, FDG PET, I think, is going to be extremely helpful in terms of looking at these issues because you can actually characterize between inflammation, which may be present, and infection based on the intensity of the FDG uptake. So, that's also an area that's growing in terms of being able to look categorically at these kind of issues.
Yeah, so last regurgitation lesion, I think oftentimes really no need for CT for diagnosis of regurgitation because 3D TE is excellent, especially in mitral valve position. But if the planning of percutaneous is on the table, I think like this case highlighted, TE would show severe paravalvular leak of prosthetic aortic valve, but you cannot really, because of the artifact, localize and quantify the size of the lesion. So CT in this case could be very useful. This just real quickly, we done.
So I just want to just comment on that last one about localization of paravalvular defect, and I see Parmraj at the back. So we've had a fair bit of experience with that, and sometimes on a TE, you look at the mitral clock face and you think it's at 9 o'clock based on the color. And it can be just frame rate issues, and then the CT we review, and on CT somebody says it's at 6 o'clock, so we would be off by 90 degrees. But Parmraj, we've had great experience. We'll take the CT data set and we sort of go through it and we tag it and we import that data into the fluoro suite, and we project it on the fluoro screen, and putting that X there, and all of a sudden things make sense. And more often than not, it's an issue of interpretation and nomenclature, and do we really all talk about the same clock face? as opposed to actually the imaging modality missing the defect.
Depends what clock you're using. Is it an iWatch or?
That's right. Yes, it's Roman numerals.
Yeah, I think that the issue is because the CT community, we haven't come out with the standardized reporting. So that's a matter, but we are aware of the problem, and so we'll do more research and hopefully publication in that regard. But last, I just want to show you the little experience that we have. Is, of the last 10 years, we managed to collect 23 cases of patients with redo valvular surgery. Essentially, we compare CT to the TE. Obviously, this is a very highly selective population because all these patients went to the OR or percutaneous procedure. So basically, compared to intraoperative finding, both TE and CT was able to correctly identify the etiology in terms of obstruction or regurgitation. So CT did a little bit better, identified etiology obstructive valve like TE compared to intraoperative finding. And not surprising here because obviously the patient had a TE, and oftentimes if we have a question like the case we highlighted, got a CT. So essentially we found that, as Dr. Zoghbi mentioned, the only case that CT missed was a very small panus that we couldn't see in the CT. But the most important thing that Dr. MAHMARIAN mentioned is extravalvular information that we obtained from CT in terms of coronary angiogram. Like in our series, 9 out of 22 patients didn't have to go to cath lab for angiogram, and to avoid potentially more dangerous procedure in this very sick population. But again, this is the last thing I want to show, that we're working actively with Colin and Ponraj here to establish how clinically effective and useful is the CT-guided valve closure. Okay, with this, I'll pass it to DIPAN for the next portion of the.
Just not having necessarily skin in the imaging game, you really want both. I mean, I see them as complementary. I mean, you need the echo to sort of quantify things and somewhat localize things, and you need the CT to define the anatomy and where the lesion is.
Let me give you my recommendation. You want recommendations today. We've written the guidelines back in 2009, and we didn't stick out our neck to say what you need to do for a prosthetic mechanical valve in the aortic position. My recommendation now is for a prosthesis, mechanical prosthesis in the aortic position. If you're concerned about its function, you certainly do the first is a 2D Doppler surface echocardiogram and take a look at the hemodynamics of the valve. If there is a question about function, meaning the gradient is high, your Doppler velocity index is kind of borderline, and you're wondering whether this valve is obstructed, yes or no. We're not talking about endocarditis. We're not talking about other issues. You're concerned about obstruction. The next step is not a transesophageal echocardiogram. I can tell you that. And the reason for it is there's no way for sure you're going to tell that the motion of the prosthesis is normal. Vast majority of the time, you're not going to see it. Complete opposite for a mitral mechanical prosthesis. Mitral mechanical, TEE, is your second choice. But for the first scenario, mechanical aortic prosthesis, if you're concerned about obstruction or a possible prosthesis-patient mismatch, or you're really not sure, the second one is a radiological one, and you could decide which radiological one to do. Sounds like a CT, even without an A, is important for you. If you want the A, you have to decide, angiography, you have to decide whether the right patient to do it. But it is not a transesophageal echocardiogram. Unfortunately, you're not going to have an update for this because we're doing an update coming up hopefully next year on whatever all these percutaneous procedures. But I think there is enough data in the literature, enough experience to say transesophageal, yes, you'll do it. We'll tell you most likely it's functioning well, but we're not going to be sure. So I really think we'll save the cost, we'll save the discomfort for patients. To do next step will be a radiological, whichever way you want to see these valves opening and closing and maybe understand the mechanism, whatever it is that you want to do, but it's radiological.
Okay.
And the other thing is when you're doing your radiological measurement, Sometimes the valve seems to close fine, but you're not quite sure whether it's opening fully. These angles are very specific. They're very consistent from the manufacturer, and you can get those angles and measure them, and you can be sure even if it's 5 degrees, you've got a dysfunctional valve.
Okay, so that was a great discussion. I'm going to flip the table a little bit here. I want to touch on safety because I get, almost once a month I get a call. Obviously, right, safety with MR is very important. About once a month I get a call asking, are these metallic valves safe? And so I want to address that issue. So there actually has been studies that have been done to look at basically what are the forces required to pull a mechanical valve out from the tissue when it's sewed in properly, and it's about 4.7 Tesla. So right now, clinically we use 1.5 or 3T scanners, so until we get our 7 Tesla scanner, I don't think this is going to be an issue. So most of these valves are safe to image. So I think that's the first thing I want to address. The other important thing, obviously, is the artifact. And just like with CT, you get artifact on MR. We're certainly doing things to try to figure out ways to reduce the artifact, but as a result of that, I think for a mechanical valve, the artifact with MR is going to be pretty significant. Now, it doesn't mean we can't get some general assessment of how, if it's a tilting disc, how the leaflets are moving, but I wouldn't really use CMR to try to really quantify motion of a mechanical valve. And also, because of the artifact, I think CMR will be hard in a mechanical valve to quantify transvalvular gradients or transvalvular velocities. On the flip side, though, bioprosthetic valves, generally the amount of artifact from those is much less, and you can usually see the leaflets reasonably well with bioprosthetic valves. So if it's a question of bioprosthetic valve stenosis, that we can generally manage, and that you can generally get some assessment of with CMR. And in fact, one of our former fellows did a comparison between transthoracic echo and CMR for assessment of valve area, showing in fact that there's a fairly nice correlation for these bioprosthetic valves. Now the key here is the cohort that he looked at were a cohort where the artifact was not significant. You could really visualize a valve. So the other, really the strength of CMR though, I think, and that's what we're going to try to highlight here in the next 15 minutes, is in valvular regurgitation. And so, I think most of you have heard me talk about native valve regurgitation and how we do it for CMR. For the aortic valve, it's really by what we call a direct methodology where we place an imaging plane directly above the aortic valve, and using our phase contrast technique, we can actually measure the amount of flow that's going forward across this plane and the amount of flow that's going reverse, and therefore the amount of aortic regurgitation. Whereas for the mitral valve, the methodology that we use is what we call an indirect method, where we compare the stroke volume of the ventricle by planimetry of the end diastolic and end systolic volumes compared to the outflow through the aorta using the phase contrast technique. So you'll notice that for regurgitation, with both of these techniques, we're not really doing any imaging specifically at the location of the valve. And that's why whether it's a mechanical or a bioprosthetic valve, for regurgitation assessment, really doesn't matter. The artifact really doesn't matter. And so I'm going to try to highlight that by showing a case. And so our fellow, Dr. Yang Zhan, who's one of our advanced imaging fellows, is going to start off by presenting a case, and then we'll wrap it up with kind of what our recommendations are. Go ahead.
Great, thanks, Dr. Shah. So I'll quickly discuss about a 91-year-old gentleman with severe aortic stenosis, NYHA class 3 symptoms. He underwent a TAVR 1 month prior that was quite uneventful. After the procedure, post-echo showed a gradient drop from 40 millimeters per mercury to 6, and also mild paravalvular leak, and he symptomatically felt better. He was discharged, but 2 weeks later presented to an outside hospital because of worsening dyspnea. At that time, he was found to have a pleural effusion that required thoracentesis, which he symptomatically felt better, but presented to us 2 weeks after that with, once again, worsening dyspnea. His past medical history is significant for coronary artery disease, dyslipidemia, hypertension, atrial fibrillation, and a pacemaker that was implanted prior to the TAVR. And his medications are on furosemide, simvastatin, digoxin, and apixaban. So on physical exam, he's slightly hypertensive at 154/64, but all of his other vitals are quite within normal limits. He is euvolemic. There's no jugular venous distension, ascites, or peripheral edema on exam. On lung exam, there was decreased breath sounds to the bases, and on cardiac auscultation, there was a 2 out of 4 diastolic murmur. So his EKG showed rate-controlled atrial fibrillation, a left bundle branch block with backup pace rhythm. So a transthoracic echocardiogram was ordered, and we can see here a preserved ejection fraction, a left pleural effusion, and also the TAVR, which was an Evolute 29 millimeter core valve in place. On short axis imaging, it is difficult to see if there's any paravalvular regurgitation, but color of the 3-chamber and 4-chamber here, we can demonstrate some aortic regurgitation, likely paravalvular with some mitral regurgitation. And that's what we thought. So we thought there was normal prosthetic valve velocity and gradient, mild to moderate, mild paravalvular aortic regurgitation, and mild mitral regurgitation. To better assess the degree of paravalvular aortic regurgitation, a TEE was ordered. And on the first image, we can see that the Evolute core valve may be slightly lower in the LVOT. It was estimated around 15 millimeters below the aortic sinus. And we can see that the mitral regurgitation may be slightly more significant. And to better assess the degree of paravalvular regurgitation, more images were taken in the short axis. And you'll see them here.
I mean, it's clearly very, very low. I didn't see the images immediately post-procedure, but the leak is because it's low. You know, there's nothing sealing. There's essentially, you know, chicken wire at the annulus, so there's no material there to seal, so that's just wide open PVL. There's no skirt there. I don't know if it moved or if it was left this way.
Okay, I know you're not done yet, but since the images are there, I think it's very important for the imager, particularly for echo. These valves are different than surgical valves. Surgical valve is easy. I'm not talking about putting it in, but easy to image. And the reason for it, you have a ring. And if you're imaging with a tomographic image, you know you're at the ring. So if there is regurgitation, you're going to see it. For these prostheses, they're long. So when you start seeing a prosthesis in a cross-section, you're not at the level to detect the aortic regurgitation unless you are at the valve itself or even below it. So some of the images that you saw and you're displaying here don't show any regurgitation. It doesn't mean it's not there. It means that you're above the valve and still see, you know, the chicken wire of this prosthesis. So the recommendations that will be coming out, okay, in a year, is you have to scan it from top, gradually all the way to the bottom, and find the start of this aortic regurgitation. So you have to do a full scan, judicious scan, for you to be able to see it. Otherwise, you're either going to miss it. 2, you may overestimate it because most of these are paravalvular eccentric jets. So it is very difficult by color. Yes, you'll detect it, provided that you do the right thing, but you want to also make sure that you're getting it at the site of where the regurgitation is. So this is the issue with imaging with echocardiography using color Doppler. And it is an issue. It is a big issue.
You showed the MR briefly. How bad was the mitral regurgitation?
So we concluded that the mitral regurgitation was mild to moderate.
Mild, okay.
Okay, so to better assess the degree of paravalvular regurgitation, even though we concluded that it was mild paravalvular, there was a suspicion that it was worse, so a CMR was ordered for this. And here we can see 4, 3, and 2 chambers showing the core valve in place. And when we measured it below the annulus, it was around 15 millimeters. The ejection fraction in this patient was quite robust at around 80% with a stroke volume of 120 milliliters. So with MRI phase contrast imaging, we can detect flow. And here on the left-hand image, we can see on the bottom image there, in diastole, there's this large area of white, and that correlates to the top image of aortic regurgitation, and from its location, it appears paravalvular. From the images on the right, this is a short axis cut near the LVOT. We can see that there is aortic regurgitation, which is white, and it's circumferential all around the valve. To detect the amount of aortic regurgitation, as was previously described, we can directly measure at the level just above the valve. And we got a regurgitation volume around 50% and a forward stroke volume of 100 milliliters through the aortic valve, giving us a regurgitation fraction of 50%. And to help further assess the degree of aortic regurgitation, we can see that in the descending thoracic aorta, that on the right there's holodiastolic flow reversal. And lastly, to assess the degree of mitral regurgitation, we do it indirectly, and we ended up with a mitral regurgitation volume of 23% and regurgitation fraction of 32%. So what did we think at the end? So we thought there was severe paravalvular aortic regurgitation, regurgitation volume of 50 milliliters and regurgitation fraction of 50%, that the TAVR valve was in the low aortic LVOT position, and that there was mild to moderate mitral regurgitation. So when we put this all together, this was a 91-year-old gentleman who was treated with a TAVR and had improvement of symptoms initially, but then the last 2 weeks had worsening shortness of breath and dyspnea and is in NYHA class 3 heart failure. And on CMR, we found severe paravalvular AI with mild to moderate MR with a low implant. So I'd like to just briefly ask the panel what they think the management and intervention should be carried out.
Before we get to that, first of all, I think these are beautiful pictures, and in our setting here, I think this was very much the way to go in terms of getting the full picture. But our trainees may go out and practice in other places where they may not have the access to the refined cardiac MRI that we have here. So one question I want to ask Colin is, with the information that was provided with the TEE, would you have felt clinically, from the point of view of all the experience, that this paravalvular leak was already quite significant, and the decision-making would have probably be similar with or without the MRI?
Yeah.
And I'm asking mostly because, you folks are going to go out, practice in other places. You may not have this great MRI that we have here, and you may have been stuck just with that TE finding, and you have to then sit down and make that decision.
No, I mean, I was thinking that. I mean, DIPAN's not going to like this, but when I looked at it, I was like, we don't need an MRI. We know the problem here. The valve's too low. It needs to be fixed, regardless. And the guy's symptomatic, and there's enough leak there to give him his symptoms. We just know mechanistically this valve is not working in that position, so something needs to be done.
From my own perspective, actually, I was very interested in the mitral regurg because sometimes we might not do quite as well. And in a 90-year-old who's very dyspneic, you also wonder where the MR could be worse than it was.
But for the person who's going to go out and doesn't have a valve team to take a look at them, we have to be honest that the transthoracic echocardiogram, even the TEE, is not very impressive from a color Doppler point of view. And here where the challenge of these valves. There are multiple areas of regurgitation, right? And how do you handle them? Let me tell you, it's a challenge for us to write guidelines because you could write many things theoretical, but from a functional point of view, I mean, these summated areas were significant ultimately, and I think I certainly would believe the data there. We try to get beyond color Doppler. Color Doppler has limitations because of these issues. And you try to look with pulse Doppler in the aorta and the arch in the abdomen and see if there is a reversal similar to what MRI does. It's tougher to quantitate the regurgitation, particularly if you have a mixed regurgitation, aortic and mitral. And even, I'll share that with people who are listening, is where do you quantitate the left ventricular outflow tract flow? And what cross-sectional area do you use when you have a prosthesis that is migrating down in the LV outflow tract? So it tells you about the issue. Maybe to answer that question, yes, maybe you could stabilize the patient or do an angiogram. I mean, you have to at times resort, or if the patient is stable, I would refer them to an excellent center where they can do an MRI and give you that other piece of information if the patient is stable.
Just going to ask you, Colin, is that a valve you can move and bring up, or you have to put in a new valve within?
Yeah, I mean, just to quickly, the treatment options here from a catheter perspective, I mean, obviously you could go to the OR and explant and do an AVR, but from a catheter perspective, this is not something you go and plug. I mean, the leak is circumferential, This is a self-expanding valve. If it was balloon expandable, you would just put a second valve in a little higher. With the self-expanding, you can either put a balloon expandable inside of this and push it out, but it's so low, I think most of us would be uncomfortable leaving it there. It's 2 weeks old, right? It's fairly recent, this TAVR?
Yeah, it's about 1 month old, yes.
So we've had a couple of these where we've gone in, snared them, and pulled them up, and then redone the TAVR, and that's probably what we do here.
And technical question, so
Just hearing it scares me.
So the pictures were spectacular, really, really pretty. And this 91-year-old did not have a pacemaker, but well, probably 20% get a pacemaker during the TAVI and 20% have a pacemaker before the TAVI. There was a pacemaker
He had
then?
a pre-procedural pacemaker.
Oh, well, even better then. Okay.
Well, I hate to say it, but the surgical mortality in healthy guys who are farming on their ranch at 91 is about 1%. So age alone should not be used as a parameter for diverting people from standard surgery. And they've got a 1% risk of a pacemaker. And there was a paper very recently pointing out that left bundle branch block after TAVR requiring a pacemaker was associated with an impaired survival prognosis. It just came out in JACC.
Great, thank you. So as was previously discussed, so the patient was taken back to the interventional lab. And on the left, you can see this is a contrast injection aortogram before the valve was replaced. And it was a challenging procedure, but the valve was snared back and a new valve was put in. On the right, you can see that the aortic regurgitation is less.
Is this what they call VIV? Valve in ventricle?
All right, so I'm going to extend it to Dr. Shah.
Okay, great. So, and this patient obviously did well clinically afterward. Let me, in the interest of time, I'm going to skip to the very end. And we're going to wrap it up. And there's one thing I do want to touch on, which is, obviously we're going to see more and more patients now with these paravalvular regurgitation after a prosthetic or after a TAVR valve. There is some data looking at the predictive value of CMR in paravalvular regurgitation, showing in fact really that a regurgitant or a fraction of more than 30% actually is associated with an adverse outcome. So again, it's not the severe that we think of as 50% or more, as it was in this particular example. And in that particular study, what they found was obviously that there's a worsening outcome with increasing regurgitant fraction. Interestingly, that regurgitant volume was not predictive in this cohort of 150 patients with paravalvular regurgitation. And I think it's probably in light of the fact that, when you see post-TAVR aortic regurgitation, it's probably a different phenomenon than the standard native valve aortic regurgitation in the sense that it's probably much more of an acute phenomenon. You're dealing with a pre-existing ventricle that's starting out with an AS ventricle that probably has concentric LVH and a small cavity size. And so again, make sure we just don't get fooled by saying, oh, it's a small volume of regurgitation, therefore it can be significant. In fact, at least the CMR data suggests that the fraction is much more predictive than regurgitant volume is. Now, let me wrap up with two things. One is, this is an example when you would not want to use CMR, which is if your concern is about endocarditis. All right, here's a great example where you can see a vegetation on CMR, but oftentimes, vegetations are very small, highly mobile, and very irregularly mobile masses that you really won't be able to see on a CMR. So missing it on advanced imaging doesn't exclude the presence of a vegetation. So therefore, really, that's one indication I would say you should not refer a patient for CMR for. However, if you're looking for complications of endocarditis, such as in this example here where you've got a pseudoaneurysm, CMR, just like CT, can be useful for looking at the complications. So to wrap up now, here's kind of the algorithm that Sumin and I propose. Which is obviously, when you have a patient that you're suspecting prosthetic valve dysfunction, transthoracic echo is going to be your first line test. If the question is really about obstruction, as I think we've touched on, there may be a role for transesophageal echo in some cases. There may be a role for CT in some cases, especially if it's for the aortic valve. And then CMR could be helpful in bioprosthetic valves, but in mechanical valves, I don't think there's really a role for CMR if you're looking for obstruction. On the right-hand side, if you're dealing with regurgitation, then TE could be a modality, but this is where I think CMR could be very useful to quantify the severity of the regurgitation and look at the remodeling of the ventricle. And then CT could be helpful if you're thinking about doing percutaneous repair of this to try to help localize the exact location where the defect is. Obviously, it'll be important to make sure that we standardize the nomenclature so that the CT folks and the echocardiographers are speaking the same language. And then lastly, I think as Suman touched on, in the setting of endocarditis, echo is really going to be your primary modality. There may be a role for CT or CMR if you're looking for complications of endocarditis, and there may be a role for PET-CT if the diagnosis of endocarditis is not clear. And then lastly, Suman, I guess the last indication obviously is in patients that are going for redo surgery, CT could be helpful for surgical planning or as an alternative to coronary angiogram. One thing I will kind of highlight or comment on, which is when you do CT, I think it's going to be important the way that you do the CT acquisition. And so as a referring, you want to make sure you order or request the right acquisition, right? Which is if you want to see motion of the valve, it needs to be a retrospective gated CT. Whereas if you're just interested in the coronaries or surgical planning, it can probably be done with just a perspective gating with lower radiation dosage. Okay? So any comments or questions? I know we went a couple minutes over. Bill?
One comment. I like the proposed algorithm with a tweak as along the line of what I mentioned before. If you take a look on the left for obstruction, CT or radiology should be before transesophageal echocardiogram. For aortic.
For aortic.
For aortic. And you may want to look at differentiating aortic from mitral because they're different, really different situations from an imaging point of view.
Yeah. Great. Any other comments from the audience? So
just one quick question on your recommendation for detection of a patient returns with early aortic stenosis in a bioprosthesis looking to rule out sinus thrombus formation.
Yeah, Suman?
In terms of, I'm sorry, the question was?
Accumulation of thrombus early after, like the 12% incidence with TAVR and the 1 to 2% with surgical valves due to sinus of Valsalva, thrombus accumulation.
Yeah, we've done several cases, and we haven't systematically looked at our experience here. This is all published in New England Journal of Medicine, and I think the incidence is probably the same between the percutaneous and surgical valve. But again, this is one of the hot topic, and Colin, you can correct me. I think there's some ongoing prospective study going on to look at this issue.
Yeah, I mean, I think Dr. LAWRIE, you're asking about the 40 CT, and that's part of all the clinical trials now because there's a rate there, it's sort of undefined prospectively of this thrombus formation on these leads.
The reason I asked is we've had a couple of cases and we did all three, and all five of us weren't sure whether what was in there or not. It's a difficult area.
Yeah, I mean,
I would say transesophageal or CT would be the ones to look at a bioprosthesis, whether there is more early thickening, because some of them may be just early thickening as opposed to a thrombus, and there are some larger thrombus. So you want high spatial and temporal resolution for this, and I think TE and CT at this stage of the game is probably, from a structural point of view, I think would be the best.
Well, I want to thank the audience, thank the fellows and Dr. Chang, and then our panel for really an outstanding discussion. Dr. Zoghbi, Dr. LAWRIE, Dr. Little, Dr. Quinones,
Dr. Barker.
Dr. Barker. I'm saving the interventionalists for the end. Dr. MAHMARIAN and Dr. Barker. I think we're really fortunate that we've got such great interventional surgical colleagues, and that we've got such great imaging modalities available. And so I want to thank the audience last for coming.
That's great. That was good.
All right.
That's tomorrow, man?